Have you ever stopped to think why one patient receives normal saline and another receives lactate rangers, and how that choice can completely change the clinical outcome and your answer on the NCLEX? Today, we're going to talk clearly and directly about intravenous fluids, when to use each one, and how to reason through these questions exactly the way the NCLEX presents them. Let's start with a golden rule. The NCLEX doesn't test memory, it tests clinical judgment. Every time you see a question about IV fluids, ask yourself one simple question. What does this patient need right now? Volume, water, or proteins? Let's talk first about crystalloids. Crystalloids are almost always the first step. They are solutions that move easily between compartments and help restore volume. When the patient is unstable, the NCLEX wants you to think fast. Isotonic crystalloids. These are the most common ones on the exam. Normal saline 0.9% and lactate rangers. When do you use them? When the patient has hypovolemia, dehydration shock, or fluid loss. If the question mentions hypotension or tachycardia, cold skin, or delayed capillary file, think immediately isotonic. Normal saline is safe and compatible with blood transfusions, but it can cause fluid overload. Lactate Rangers is more similar to plasma and is widely used in trauma and burns, but is not the ideal in severe liver failure. Hypotonic crystalloids. Now, the ones the NCLEX wants you to use carefully. 0.45% normal saline and D5W after it is metabolized. What are they used for? When the problem is inside the cell, such as a cellular dehydration or hypernatremia. Here comes the classic NCLEX trap. If the patient has trauma, increased intracranial pressure, or is hemodynamically unstable, eliminate hypotonic fluids immediately. These fluids can worsen cerebral edema. Hypertonic crystalloids, a classic example, 3% saline. These fluids pull water into the intravascular space. When are they used? Severe hyponatremia and cerebral edema. They are always given slowly and with close monitoring. The NCLEX often asks which complications to watch for. Remember, fluid overload and neurological changes. Now, let's move on to colloids. Colloids work differently. There are large particle states inside the blood vessels and help maintaining intravascular volume. Examples include albumin and plasma. When should you think about them? When the patient does not improve with crystalloids or has a lack in oncotic pressure, such as a hypoalbuminemia. An important example, if the patient has edema, but at the same time a low intravascular volume, a colloid may be the correct answer. Rixe NCLEX always evaluates. With colloids, you must think about fluid overload and allergic reactions. That's why you should remember this phrase for the exam. Crystalloids first and colloids second. How the NCLEX frames these questions. The exam usually focuses on which fluid to start first, which patient has a contraindication, which adverse sign you should monitor, and the classic signs for fluid overload that are shortness of breath, crackles, jugular vein distension, and rapid weight gain. Let's review the final summary to answer with confidence. Hypovolemia, isotonic fluids. Cellular dehydration, hypotonic fluids. Cerebral edema or severe hyponatremia, hypertonic fluids, and failure to respond to crystalloids or hypovolemia, colloids. If you think this way, you're already answered like the NCLEX. And now let me ask you, how many questions could you answer correctly just by understanding when to use each IV fluid? If this content helped you, we invite you to join to Enfermeras en USA. Save and share this video and follow us on all platforms to continue preparing for focus, confidence, and strong clinical judgment for the NCLEX.